Good evening, folks. Welcome to another episode or another installment of the St. John Ambulance Division 176 lecture series, online lecture series. Tonight we have Anna Stefik, Divisional Superintendent for 176 and a primary care paramedic with the Provincial Ambulance Service, doing a second installment of assessments and treatments in the pre-hospital setting, a review of. For those of you who attended the session in March, this is going to be, I believe, and Anna can correct me if I'm wrong here, I believe this is going to be very similar to that event. And I'm gonna hand everything over to Anna and leave her to guide things from here. Oh, nearly forgot. I think all you guys know this, but do please keep your microphones and video off throughout the presentation. The reason for this is that Zoom does record the extra stuff as well. So if you do turn your cameras on, we just when we record this and post it to YouTube, it ends up it means that we have recordings of you sitting there eating your dinner or whatever, and it's would like to give you a little bit more privacy than that. So there you go. Anyway, over to you, Anna.
All right, thanks for the introduction, Nicholas. So the last session of these virtual sims that we did a couple months ago was very popular. We got a lot of good feedback, people wanting more of the same style of this. So we're gonna do another one today. So I hope you guys enjoy this session. For this one specifically, the scenarios will be taking place now. So during the COVID era. So when we talk about entering a scene or hazards or whatever, I want you guys to consider what sort of PPE you want to bring with you, what you want to put on. So think of these as duties that would be happening now. The last session we did, we had everybody interacting in the chat box, and that seemed to work really well. We got feedback that that was the preferred method versus having microphones off. So as we go, put your feedback in, put your ideas into the chat box, and I will be reading them off as I go. For these scenarios, just for the benefit of some of the newer members or people who need to maybe jog their memories a bit, we're going to run through these scenarios in order of the patient assessment model. So when we run them through at the beginning, I'm not really expecting you guys to ask for vitals as the first thing. Let's run through airway, breathing, circulation, and so on. But I will do my best to answer the questions as they come up. So yeah, throw your stuff in the chat box. At the end of each scenario, there is a break for question and discussions, and we will go through the St. John COVID era PPE and treatment guidelines in this presentation as well. Just because I know there's more duties kind of starting up for people. There's a lot of vaccine clinics happening. Most of us have not been out on duty in a long time, so this stuff is a good refresher. So think about your PPE, your treatment guidelines, all that stuff as we go through these sessions. And with that, we will get started. If I can make this move. All right. No. There we go. Okay, so just to recap, this is our patient assessment model. So as we go through, we're gonna go through our scene survey. So that's your HEMP, your hazards environment mechanism, patient's PPE. So think about what PPE you want to bring based off of what you know about this call. Your primary, we all know, delicate spine, level of consciousness, airway, breathing, circulation, rapid body survey, and then your SOAP, and then we'll go into your secondary, so your history taking, your sample, vital signs, and then treatments that you want to do. At the end, in the portion where EHS arrives, it would be really great to do a handover for the benefit of everyone else. So we'll see if anyone's up for the challenge. For the purpose of these scenarios, just like before, EHS will arrive kind of when we're ready for them to arrive. So I'll let the scenarios go for a while until they kind of naturally come to their end, and then we'll have EHS arrive when we feel we're ready. And with that, here is scenario 1. So put your stuff in the chat box. So you and your partner are volunteering in the medical clinic at your local drop-in center / shelter. Around 11:30 a.m., there is a call on the site radio requesting medical aid on the 4th floor of the housing unit. One of the residents states he is having some trouble breathing. So with that, you and your partner get ready to respond, and you need to grab some equipment to go up there. What do we want to bring? All we know is that someone says they're having trouble breathing. First aid kit, absolutely. Oxygen, I would say so. Kit with oxygen, yeah. AED, yep. Vital signs kit, extra mask, yep. PPE, what sort of PPE are we bringing for this call? Medical mask, yep. Face shield, totally. Gloves, gown, yes, gown. We're basically bringing the whole deal because we're thinking this might be a respiratory call, so we want to be fully protected on it. Okay, with that, so we've grabbed our first aid kit, we've got O2, we've got an AED, and we've got PPE. Let's do this. PPE for the patient, yep. We're going to reverse isolate our patient. So we go upstairs and we're met by one of the staff members, and they say they were doing the rounds of the floors, kind of getting people ready to go down for lunch. When they came into his room, the patient was saying that he was feeling unwell and he felt like he had some difficulty breathing. Okay. So general impression as you walk in, the housing units, the rooms themselves are quite small. There's basically kind of like a bed, a small living area, and you see a male in his 60s. He's seated in a recliner and he's watching TV. When you walk into the room, he's alert and he's tracking you. So this is your patient. Is there anything we know just by kind of walking in and seeing him? Anything we can glean from this scene before we even talk to him? Yeah, he's got a walker. Yeah. His color's good. Yeah, I wouldn't say there's anything about his skin just by the outset. You're not seeing any cyanosis. He might be a little bit pale, but that might be his color. One of you goes into treat and one of you stays back. Yeah, that's a good point from Chris. Limiting the number of people inside a room or inside a small space is always a good idea. Check his breathing. All right, so let's jump into your ABCs. So his airway is patent. His breathing is rapid and shallow, but he's speaking in full sentences to you. What do you want to know? Is that his normal? No. So he says he's having a bit of trouble breathing. How long has he been having these symptoms? So he's able to speak clearly when he's talking to you. He's not kind of interrupting his speech to say these things, but he tells you that he's been short of breath for the last 2 weeks, but it's been getting worse the last 3 days. And he went into the hospital 2 days ago and was prescribed a water pill. Someone asked to check his pulse. You check his radial pulse, and it is rapid and irregular. Does anything make it better? Does anything make it worse? So he says when he's just sitting down, He feels okay, but as soon as he gets up to walk around, he does not feel good at all. He starts feeling dizzy and he gets more short of breath. Can I hear any wheezing or coughing? So you can't hear any wheezing. And he says that he always coughs. Is he feeling dizzy? Not right now. And someone says, can you auscultate the chest? Yes, we can auscultate the chest right now. When you take a listen, the sounds, the lung sounds on his right side, right lower lung are diminished. Everywhere else you hear crackles. Any edema? Yes. So as you go down, you do your RBS. This is what you see. You lift up his blanket and these are his legs. Does he smoke? No, he does not. Why was he given the pill? So he went into the hospital 2 days ago with the shortness of breath and he was given a water pill to clear some of the fluid from his lungs. Does he feel dizzy when he stands? Yes. So he says he feels okay when he's just sitting down, but as soon as he exerts himself, his shortness of breath gets worse and he feels dizzy. All right, so people are asking about his medical history. So he tells you that he's got a history of diabetes, he's got hypertension, and he has a history of CHF. So when he was in the hospital 2 days ago, that's what he was treated for essentially. Is this normal for his legs? So with his diabetes and his CHF, so he tells you that these dressings he did himself. He would normally have a home care nurse coming, but he missed his last appointment, so he did this on his own. So you notice that there's quite a bit of swelling up in here, and he's tightened this pretty tight. So he's got kind of swelling up here, a bit less here, and then he's got these kind of weeping wounds. So this is a combination of his diabetes and his congestive heart failure. Okay, so people, okay, Sheena says, consider starting some low flow oxygen. All right, so oxygen is a great idea. We can do some vitals right now. I will give you the first set of vital signs. So we've got a heart rate of 120. We've got respirations of 38 while seated. His blood pressure is 154 on 96. His sats are 77% on room air. And his skin is as you saw it in the picture. So maybe a bit pale, but warm and dry. So Sheena says, let's start some low flow oxygen. What kind of oxygen do we want to put on him? Give him high flow. What do we want to do for him? Call an ambulance. Yes, I would do that. Maybe high flow. Yeah. Callum says, call EHS non-rebreather at 15 liters per minute. Yeah, okay. I think everyone's in agreement now. So high flow oxygen via non-rebreather. We've called EHS. What would we like to know, or what would we like to do? And I apologize if I've missed some of the comments. Someone says, can we take off the dressings and assess for infection? Yeah, you absolutely could get a better look, get a better picture of what's going on here. Redo the bandages, dig into history, allergies and meds. Okay, so allergies, he's allergic to metformin. Medications, he doesn't really know, so you search the room a little bit and you find prescription bottles for Toradol, Zopiclone, and furosemide. Are his feet getting adequate circulation? They look a little too tight. Yeah, so you can loosen them off and check out his circulation. Put a face mask over the non-rebreather if he'll let us. Yeah, just to kind of reverse isolate. Does he have family in the house that can provide us more background? No, so he lives in a housing unit. So it's only staff that that would be there, but they don't really have much more information. Elevate his legs. Okay. So we've kind of got a history. We've got one set of vitals. We've put some oxygen on him. Do we want to kind of get moving? Do we want to position package? What do we want to do for him? Anybody? Keep going with vitals, prep for transport. Okay. I'd leave the legs alone package. Okay. It's not ILI, maybe moving. Okay. So the last few comments say, let's start moving. So how do we want to move this person? Can you give a quick explanation of the meds? Just something brief. Yeah, so Toradol is a pain medication. Zopiclone is often used as a sleep aid, and furosemide is a diuretic. So that's the water pill that's he's been put on to kind of get the fluid off of his lungs and excreted from his body. Get a wheelchair. Don't move until the medics arrive. Can you stand for short periods to the gurney or their stairs? So there is an elevator leading up to the 4th floor. Stair chair or cot, want him to do as little work as possible. Other people say don't move. Okay. So we're kind of split on this one. Some people say don't move him, and some people say move him, but move him as little as possible. Cot can come into the elevator. It's been going on for 3 days. He's relatively stable. So yeah, he's been put on that water pill. He says he's taking it, but it sounds like it's not really kicked in adequately yet. How is his urine output? He says he has been peeing a lot. Would you move him if BCAS is coming? Is he on insulin? Yes, he is on insulin. When did he last eat? He was just about to go down for lunch. So he would have had breakfast around 7 a.m. Okay, so it seems like most people are leaning towards putting him in a stretcher and getting him moving because EHS has been called, but they're a bit delayed. So he's sitting in a recliner. You can bring the stretcher right up to him. How do we want to move him? And is there anything you want to do before moving him? Keep him sitting. Okay. So are you saying don't move him? Another set of vitals. Okay, let's do that. So right now with the high flow oxygen and at rest, his heart rate is 110. His respirations are about the same. They're at 36. His blood pressure is pretty well unchanged. It's still in the 150s, but his saturations have gone up to 91% on the oxygen. Okay, so yeah, the room is essentially split. Some people say reassure him and wait. Others say sit the recliner upright, lower the stretcher to matching height right beside the chair, and if he can slide over, help if needed. Just leave him comfortable with oxygen and wait for the ambulance. Yeah. Okay, so I think we can wrap this one up. Let me get this moving. Would 911 advise? So generally the call takers tell you or tell the caller to not move patients, I think is my general understanding, because they are kind of coaching every kind of layperson, right? So the call taker does not know what someone's background is, and they don't necessarily know what equipment you have, and they don't know your comfort level. So the script they give you is general for everyone. So they pretty well always say, don't move the patient. Okay, yeah, so we're totally split on moving or not moving. So EHS arrives. Kyra says, if they tell us not to move the patient, can we ignore that? Yes, you can, depending on what you know and what you're comfortable with and what, like, who you have to help and what your equipment is, right? Like if it was, you know, me and a colleague from work off duty and we came across this patient, the care we would give versus someone who doesn't have a first aid background would be totally different, right? They tell it to everybody. They just have a script that they read. So it's really like if you're a ER doc and you have an off-duty ER nurse with you, the way you run that is going to be different, right? The call taker's saying a script that will have the most benefit to the greatest number of people, right? And no, if you do it, but the call taker said you shouldn't, it's not going to go against the call taker, right?
This is a really, really good discussion, Anna, but I just wanted, or I have a couple thoughts on this. Do you want to finish the scenario first, or do you want me to jump in with some thoughts on moving this patient right now?
Let's finish the scenario. Okay. I mean, it's pretty well done. If anybody felt like turning on their mic and giving a handover to EHS. No, that's okay. So basically when they arrive, you want to paint a picture of how the patient was presenting when you arrived and what you did and what effects your treatments had. So for him, you would say something like, this is Jim, he's 65 years old. Today, Jim is complaining of shortness of breath. He's had it for about 2 weeks and it's been getting worse in the last 3 days. He did end up in the hospital with it 3 days ago. He was put on a diuretic, but he continues to have worsening shortness of breath. When we arrived, Jim was presenting with room air sats of 77%. He was breathing at 40 breaths a minute. We put him on some oxygen and we left him resting, and now his sats are at 91%, blah, 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 blah. Into his medical history, he's got a history of CHF, diabetes, he's on these medications, and these are his vitals, right? So you want to really paint a picture of the history of what happened, what they looked like when you first saw them, what you did, and how they are presenting now. So we're not necessarily rattling off, you know, vital signs, but just tell a story. Who is this patient? What happened? And with that, we can get into a discussion because there's there's a lot of comments on this one. Nick, you can go for it.
Yeah, I just wanted to talk about this. So I have the benefit. I've met this guy before. I've met this patient before, and by this patient, I mean the archetype that this patient represents. I think a lot of us that work as PCPs, and I don't know if we have any ACPs or RNs joining us tonight, have met this guy, or this patient. This is a very, very classic CHF presentation. And you have to be so cautious with these people because the capacity, or the potential, I should say, for a CHF patient to decompensate on even the slightest exertion is, I can't underemphasize, or I can't overemphasize that enough. This is the guy who will code on you when you stand him up. This is the guy who will literally go into cardiac arrest when you stand him up. And unless you've seen a whole bunch of these and you're really comfortable saying, I think based on all of this stuff and my clinical judgment, and I've seen presentations like this a million times before, and here's all the underlying physiology, I'm pretty sure that I can get this guy onto a stretcher, and you have a good reason to do that, my inclination would be to probably leave him where he is until you can get some stability for him. I don't recall the vital signs you ran off, Anna, earlier, but this is a guy, an unstable or a pseudo-stable CHFer. I'd probably be looking at some vascular access, like placing an IV and having a line in place before I tried to stand and transfer him, depending on how severe his presentation was. It's a big gray area, because there are lots of these people who have a CHF exacerbation and are going to be fine to transfer. And there's a lot of them that have a mild CHF exacerbation, or a moderate CHF exacerbation, or a moderate to bad CHF exacerbation. And teasing out the difference between that moderate CHF exacerbation where you can do a stand and pivot and transfer, versus the guy who's, I see Brian Mikowski saying 77 oxygen. So his room air sats were 77. Is that right, Anna?
Yeah.
Yeah. So
but 91 on non-rebreather at 15. So
yeah, I'd be very cautious about moving that guy without some friends handy, and I'd sure make sure that I had my AED and all my code stuff ready to go. And if I was at work wearing my work uniform, I would probably have vascular access and a couple more friends handy before I tried to move him. This is someone, to me, that, depending on what his work of breathing was like, and depending on what his pressure was like and all this stuff, would probably be attracting an advanced life support crew as well. Um, if you for some reason need to get this guy out of where he is, you're in an unsafe situation, and the situation's not ideal or whatever, and you're like, no, we got to get him on the stretch, we need to get him out to wherever we can manage him and assess him better. Sometimes that's the way things are. But I'd just be really, really cautious with putting CHF patients through any kind of any kind of exertion, especially if that's their initial presentation. I'm not saying outright don't do it, but with extreme caution. I think anyone who's been, I think any paramedics who've been doing this for a while will have stories about that CHF patient that they underestimated. And like, oh, I thought he was going to be able to handle that transfer just fine. And then 30 seconds later, we were doing compressions. Just be real cautious about CHF. CHF patients have a real potential to be much more exercise intolerant. Yeah, I see one person, Andy, and sure, it's probably Andy, I'm guessing, saying being there. Yeah. And these are the guys that you go like, yeah, sure, I think he can handle it. Nope, couldn't. And then things go, progressively worse from there. So I'll stop talking now, but I just wanted to throw that out there. If in doubt, if you don't have a really strong reason to move, if in doubt, wait for friends to show up. If you don't have like a really pressing reason that you need to get out of that room or get out of that space or be somewhere else, wait for your ambulance colleagues to show up, wait for the PCPs, ACPs, whoever else has come to show up. I'll be quiet.
Yeah, so this patient, like Nick said, is truly misleading, because you get there and they don't look that sick, right? He's speaking to you in full sentences. Yes, he's breathing a bit quickly, but on the outset, he doesn't present as being that bad. And then you put the SpO2 monitor on and it's reading 77%. Right? But then you put oxygen on him and it bounces right up to 90 something percent. So then at that point, EHS is delayed. Do you speed up his transport to the hospital? by getting him down from the 4th floor to the main floor? Do you just leave him? Do you, can you move him without making that shortness of breath work or worse? But yeah, as Nick was saying, anytime with these CHF patients, they're kind of like sitting on the line of being stable to being in a really, really bad place. So if for some reason you do have to move them, prepare for that patient to go downhill very quickly is essentially it. And a lot of you were saying I'm uncomfortable moving them, and that is absolutely fair.
To jump in, if for some reason, for whatever reason, you do have to move this person, I can't think of good examples right now, but for whatever reason, the scene you're in isn't safe, you need to put this patient on your stretcher and get out of that space. Things that I would have on my checklist to make sure that I had ready before I moved him is I would have my AED out, I would have my pads ready, I would have my suction available and turned on, I would have my BVM out of the bag, assembled, I would have an airway approximately sized, present and tucked under the pillow, like all of these things to prep for a potential crash. These would be the things that I would be doing before I went to go and transfer this guy. So yeah.
Yeah, and someone comments that we were trying to keep people out of the room for precaution. There's a line that you're kind of sitting on. Like if the patient is relatively stable, you've got one person in there, you're managing everything kind of on your own. There's, oxygen is working for them. We're not doing other interventions. That's great. But if this person were to suddenly code, then your partner's going to have to gown up as well and probably get in there and help you. So we try and keep as many people as safe as possible. But when the call escalates, you're going to need some more help as well. And in that case, make sure you and your partner are safe. And yeah, no BVMs. Nick, you got your BC ambulance hat on.
Right, pardon me. Sorry, I'm sorry about that. Sorry, yeah. Yeah. I was speaking as what I would be doing if I'm at work moving this guy is maybe.
Yeah. That's okay. So with that, Nick has done a perfect kind of lead in to our little sidebar topic. The current COVID PPE and treatment guidelines. So this is just a brief blurb on what St. John says you can do right now. So again, this is just for St. John Ambulance. I know there's a few folks tuning in either from the JI or from BC Ambulance. So this doesn't completely apply to that, but this is what St. John says we can do. There's a couple more questions here. If we had access to virus filters, would we be allowed to use BVMs? No. St. John has said no BVMs right now at all. And the reason is like, if you can't secure that airway perfectly, you always run the risk of aerosolizing and spreading stuff. So St. John has just said no BVMs at all. So, okay. So really important with any patient. So this is any duty you do, anybody who comes up to you, any patient you run into during the COVID era, you want to kind of pre-screen them before they approach you, just so that you know what precautions you need to take, because we're not sitting there in gowns all the time. So we do what's called a doorway assessment. And this is one you do when the patient is still, a little ways away from you, and you just ask them a bunch of screening questions. So you want to ask for things like, have you had any recent fever or chills, cold sweats, any shortness of breath, any new onset of cough or a worsening cough, any kind of sore throat or runny nose, any nausea, vomiting, diarrhea. Have you traveled recently? Have you been in contact with anyone who's been diagnosed with COVID-19? Have you been tested for COVID in the last week or so? And have you been advised to self-isolate or quarantine? So these are some high yield questions that you ask, which will then determine what PPE you need. but do prepare that people will say no to some of these questions. And then it will come out later that they have some of these symptoms. So just because you've asked them and they said no, and you maybe haven't put on the PPE you need, you can always take a step back and put on that gown later. Okay. PPE on duties. So we're wearing surgical masks for the whole event. So you show up to the building, you've got your surgical mask on. When you have a patient, you're going to want to wash your hands, put on a face shield over top of that surgical mask, and then put some gloves on. And then you're going to complete that doorway assessment. And then if anybody has any influenza-like symptoms that you found during the screening, anybody engaging in patient care, so anybody coming right up to that patient, you also need to don a gown on top of that face shield and mask and gloves. If you have any doubts whatsoever, put on that gown. People are understanding when you tell them like, hey, it's COVID times, this is what we need to do. People are usually pretty good with it. So gown up if in doubt. And remember to reverse isolate your patient. So these days, people are normally wearing masks already, but if they are not, make sure to put one on them so that there's that double barrier happening with you and your patient. So just a quick summary of the treatment guidelines. As we've touched on, BVMs, OPAs, NPAs are no longer supported by the treatment guidelines. I'm sure after COVID ends, masses are vaccinated, this will eventually come back to St. John Ambulance, but we are not doing any kind of artificial respiration just because of the risk of that aerosolization. You can use manual suction if necessary, if you've gowned up. I recommend just rolling a person and letting gravity do its thing. It could be a bit more effective. If you need to give somebody oxygen, we are using kind of the lowest setting that we can to relieve their shortness of breath, to make them feel better, or to bump up their saturations to 92% or higher. And the guidelines kind of recommend, starting low at like a cannula at 4 liters per minute, seeing what it does. If somebody is acutely short of breath, like this patient we just talked about, I would say your training and your knowledge probably states that this person will need some high flow oxygen. So go right for the non-rebreather at 15. And somebody also mentioned putting a surgical mask over top of that mask, because it does have some spots where the airflow comes out. So you can absolutely do that. And yeah, ensure that you're in a well-ventilated area. So you don't want to be trapped in your mobile first aid post. If that is the only spot you can use for some reason, make sure the vehicle's turned on and the exhaust is on. But ideally, you would do this outside or in a larger space where there is ventilation. And then if we do need to do CPR, we are doing compression only CPR during this time. So what you want to do, you found somebody's pulseless, you're going to want to cover their face. So whether you put a surgical mask on them or like a non-rebreather, some sort of covering for their face, and you want to defibrillate as soon as possible. Maybe there's a treatable cause that can be fixed with a shock. Similarly to respiratory arrest or overdose, we are not ventilating a patient. If it's an overdose, cover their mouth and give Narcan, do compressions if you need. And somebody was asking about vaccines. Yes, you can, but having a vaccine does not prevent you from getting COVID and spreading it. You can still kind of be asymptomatic and give it to other people. The vaccine kind of decreases how severe your case of COVID might be.
I just jumped in there. I replied in text in the chat here, but we have definitely seen a couple of patients, and I have to be very cautious about how I phrase this. We've definitely seen a couple of patients who have had a who have appeared to have COVID-like symptoms even after receiving a first vaccine. Um, and this is not at all to suggest that the vaccination program is not highly effective. It is an absolutely essential tool in battling COVID. Um, but just because someone has received a dose of vaccine doesn't mean that we can let our guard down in terms of transmissibility and our PPE and all that. I just want to be very, very clear about that.
Yeah, we're still too early in the vaccination program. Like, the majority of the population hasn't been vaccinated, so there is still a lot of transmission. There's a question about maintaining an airway. So yeah, we are limited with the exclusion of OPAs and NPAs. You have to do your best with a head tilt, chin lift, and jaw thrust, and cover the person's face. You can still administer oxygen. So you could put a non-rebreather on them and, put a 15-liter flow or whatever you want and hold a head tilt, chin lift. Okay, any questions about treatment guidelines? I hope it's clear. These documents have been sent out to everybody. If you haven't given it a read, give it a read. But yeah, basically, in short, we're avoiding anything with the airway. Okay, second scenario, let's do this. So we are doing first aid at your local vaccination clinic. At 6:30 p.m., one of the security guards comes up to you and says that there's someone in their car complaining of chest pain. So we know they're in their car, they're outside, they're complaining of chest pain. What equipment do we want to bring with us? Cardiac equipment, call an ambulance, kit AED, O2, PPE, kit vitals, O2. Yeah, pretty much. So this is your scene as you walk up. This is my excellent photoshopping skills. You see what looks like a woman sitting in her car in the parking lot. What do we want to know about this scene? Do we want to do anything right here, right now? What are we thinking as we walk up? Is the car running? No, it's not. PPE. Yeah, so we're walking up. What do we want to put on right now as we walk up? So she left the vaccine clinic, walked out to her car, and then she waved down a security guard who then came to get you. Are there any cars or people around? No, so the space where she is fairly empty, but there could be cars coming at some point. Somebody says wear full PPE. So we want to gown up right now. Is she tracking or is she slumped? Okay, so this is her as you walk up. General impression, female in her 60s. She's sitting in her car. She is holding her chest and she is alert and talking to you as you walk up. And yeah, we can get security to monitor traffic around you. Ask her to put on a mask. Absolutely, she does that for you. What do we want to know? ABCs, perfect. So her airway is patent. She's talking to you. Her breathing is labored but effective. You don't see any cyanosis, and she's got equal kind of lung expansion. She's able to take a deep breath, and her pulse is strong and regular. When did this start? So basically, she got her vaccine. She sat there for 15 minutes. She felt fine. She walked out to her car. She got to her car and she had this sudden onset of chest pain. Has this happened before? So this has never happened before. And it came on, somebody's asking for OPQRST. So it came on all of a sudden after walking from the clinic to her car. She walked approximately 75 meters from the arena to her car, and she sat down and this happened. Any allergies? She's got no allergies, and she only takes one medication, and that is Tecta, which she takes for acid reflux. Did sitting help? It did not. Her skin is cool and clammy. Call EHS. Absolutely, we can do that. Change in pain on breathing or positioning? No. So movement doesn't change it. It did come on after she walked, but now that she's settled in her car, it still isn't going away. She does not have a history, any kind of cardiac history. She says she's generally healthy. Her pulse is strong and regular. Any pain on palpation? No. So when you go in to push on her chest, it doesn't change the pain. Her last meal was lunchtime, and she says she was eating and drinking normally today. Nothing out of the ordinary. Get her onto a stretcher. Yeah, we can do that. Pain anywhere else? So she says she has some lower back pain, and she says she's having a bit of trouble breathing. She says it does not feel like her previous heartburn. That's a great question. So when you delve into it, she says it is mid-epigastric, so kind of up in here, kind of a pressure. She says it's an 8 out of 10, and she describes it as a pressure. She is quite anxious, and she also talks about the lower back pain, and she says she's having a bit of trouble breathing. So first set of vitals, we've got pressure of 90 on palp, a pulse of 114 regular, respirations of 32, saturations of 96%. Her skin is cool and clammy, and she's got a GCS of 15. So people are saying vitals, then oxygen. All right, so if we do put oxygen on her, what do we want to put her on? So to answer Glenn's question, she has no known or diagnosed history of angina. Low flow cannula, no oxygen. What were the vitals again? 90 over palp for blood pressure. Heart rate of 114 regular. Respirations 32. Oxygen saturation is 96%. Skin cool, clammy, and GCS of 15. Any pulsatile masses in the abdomen? No, she does not. She does not complain of any abdominal pain. Does she respond to oxygen? It doesn't really do anything for her. Her stats stay pretty well the same, and she doesn't feel any better. People are saying bring the stretcher, put her in a laying position. ASA, yeah, absolutely. So I've seen a couple people say aspirin. What is the dose we're giving her? And has everyone kind of agreed that we want to give her ASA? Has she taken any today? No, she has not. She only takes Tecta. No allergies to ASA. People are saying 81, 81. One package from the kit. So I would give her, so the ASA we carry here in Victoria is the 81 milligrams. So I would give 2 of them for 162. And then when you put her on the stretcher, lay her down, it doesn't really change anything, but the movement from getting out of the car makes her vomit, and she vomits undigested food. Lay the seat back. I think there were questions here about peripheral circulation and pulsatile masses. So you don't see any cyanosis in her peripheries. She does have a strong and regular radial pulse. And we did move her onto the stretcher. And when we moved her, she vomited undigested food. And yes, we did call an ambulance already. Have her in the lateral position in case she vomits some more. Yeah. Did vomiting alleviate or make it worse? She still feels not so good. Palpate the abdomen, constipation. Yeah. Yeah, so she's not really complaining of any abdominal pain. What did she vomit? It was just what she'd eaten earlier. It was undigested, so she's vomiting chunky bits. Vitals post vomiting, yes. So not only have we moved her out of the car, but she vomited. So this is a total change in her presentation, in her positioning. So really good that you do another set of vitals, recheck her ABCs. So the second set of vitals that you do, you are now able to take a better blood pressure, and we have her kind of semi-reclined, and her pressure is 130 on 90. Her heart rate is 114. Her respirations are 28. Her SATs are unchanged, 97%, and she's still cool and clammy. Somebody says if you gave 162 ASA and she vomited immediately afterwards, you can give another. What about giving another 162? Yeah, I mean, you worry about her vomiting again. Is she having an allergic reaction? So she has no known allergies. It has been a while since she's eaten. It's been about 45 minutes post-vaccine. So she felt completely fine until she got up and walked to the car. Lung auscultation. Absolutely. Let's do that. So you have a listen, and she has clear lung sounds throughout. Undigested food makes me think bowel issue or food poisoning. Yes, you're on the right track. Any other thoughts? Any other differentials?
I just wanted to throw in there, I think Emma was on a bit of the right track looking for pulsatile mass. Or not right track, but a worthy investigative track. I would personally love to have bilateral pressures on this person.
Sure.
Just as a maybe not rule in, rule out, but an index of suspicion, increase, decrease.
Sure. So you do bilateral blood pressures and you find them to be pretty well matched. There's no major changes between right and left arm.
Fantastic. That makes me very happy.
When did she eat last? A few hours ago. It would be nice if EHS came with some nitroglycerin, although it seems we're leaning towards a perforated ulcer or the like. Anaphylactic reactions can show up as nausea. Absolutely. Line of questioning about her last meal and bowel urinary habits and history. Yeah, so you guys are on the right track with the GI stuff. With when we write GB, is that a bleed that we're talking about? Gallbladder. Okay. Would that be more localized, or the abdomen is a weird space and organs present their pain differently and they present differently for different people. So it's hard to say. But yeah, gallbladder would be a good kind of line of questioning. Yeah, it can perforate all kinds of trouble if she ate normally. Yeah. Okay. Well, I think we're down the right track, so we can maybe move on. Okay, EHS arrives. Anybody want to take a stab at a handover? No? Okay, so I'll give you an update on this patient. So this patient was taken to hospital by ambulance, and she was subsequently hospitalized for a bowel obstruction. So there you go. But yeah, we can have a discussion on that one now. Any comments, questions? I think just the way she's presenting with the kind of labored breathing, the chest pain, she's got some back pain as well. She's kind of pale. She's got these not so great vitals, like her elevated heart rate. She had a soft pressure at first. I think aspirin and laying her down and giving oxygen is absolutely a great way to treat this person, because she is very much presenting as a potential cardiac patient. Where in the GI tract? Yeah, I don't actually know. This follow-up came, it was a very vague follow-up for me, and it was not at a vaccine clinic. This is a patient from a long time ago. But yeah, when she went to the hospital, they did an ECG, they checked out everything cardiac. And then she was just not feeling any better. So they investigated further and found that she had this blockage in her bowel. I don't know kind of where the blockage was, but it was, the way she presented was very much not GI or abdominal, anything. It was very much a cardiac patient when we assessed her. So it came as a bit of a surprise that it was a bowel obstruction, but one never knows.
I think maybe just to jump in really fast, Sharon, I think the big take home from this, and I think you hit the nail on the head here, the big take home from this is you cannot rule this person out from being a cardiac case. She could have had a transient arrhythmia that spontaneously converted, and you would have absolutely no way to know, right, in the field. Absolutely, these patients end up having like gastric stuff sometimes. And yeah, sure, it was what we decided was a gallbladder or something like that. But for what we can do in a pre-hospital environment, just always have that really high index of suspicion that there's something else going on as well, which I think everyone did a really, really good job of in terms of like the assessments that were being done and asked for and all that. So.
Mm-hmm. And she's kind of suspicious too, because this came on after exertion. So like, is it angina? Is it cardiac? Is it not? Who knows? Like, do a really good history, treat what you see, treat the signs and symptoms. She's kind of presenting cardiac. Will giving a, potential gastric bleed obstruction, who knows what patient, 162 of ASA really hurt her? Probably not. But yeah, the undigested food is what stuck out for me. Yeah, absolutely. That means something's going on. So when you palpated her abdomen, you didn't find anything. She wasn't complaining of pain. For her, it was kind of the difficulty breathing and the kind of mid-epigastric pain that was bothering her the most. But yeah, good job. Good job. There was a lot of good treatments, a lot of good questions. So yeah, really good. And I think this is a good time to do an attendance. So for everybody who needs a certificate for credits towards their EMALB license, so those are EMRs, PCPs, ACPs, so on and so forth. Anybody who needs to claim education credits for this year, type in your first name, last name, and your email all in one line, and we will send you a certificate so that you can log this for some credits. I think generally these sessions get people 1 credit.
It's been mixed, and it depends on which competencies we're covering. I think if we're no credit, cash only, sure, Mike, I'll take cash. But if we're covering NOCP areas 4, 5, and 6, it's normally 1 credit to 1 hour, and if it's any of the softer competencies, it's 0.5 credits, I think. But EMLB hasn't. They sort of have left at their discretion for each of these, depending on what we're talking about each night. There's something I was going to throw in there, and I can't. I do as well. We have had at least one person reach out and say they're hoping to be able to use these sessions for CE credits or CME credits for a nursing qualification. We are happy to issue an attendance certificate for that purpose, if that's something you want to try and use your attendance at these events for. I have no contact with the nursing professional bodies. I have no idea what they would think or not think of these sessions. So we're happy to issue an attendance certificate. Whether or not they're going to accept those for your nursing qualification or not, I have absolutely no idea. But do feel free to throw your name and your email address in there if you're an RN or an LPN and you want to try doing that as well.
All right, I think we'll end attendance there and carry on with our final scenario. Scenario number 3. So we are at the local vaccine clinic. Again, different day, different time. So around noon, you are alerted to a potential patient outside when a woman comes in asking for help for her elderly father. So she states that she thinks he is having a stroke and can you go help her? So what equipment do we want to bring for this potential stroke patient at the vaccine clinic? BGL kit, yep. Bring all the things. Kit, AED, O2, PPE, a bed and a stretcher. Yep. What PPE do we want to wear based off of this information, or do we want to do a doorway assessment and then kind of upgrade our PPE based off of what is said? Do a doorway assessment. Yeah, so you could go into this call with your mask, your face shield, which we're wearing for all patients, and then gloves. And then if it comes out that you might need to do oxygen or this person has any kind of infectious symptoms, you can always put on a gown. I'm fine with that, but you can put on a gown right away if that is what you are more comfortable with. So this is your scene. So you're outside of the rec center. Would they have been screened before coming into the clinic? Great question. Yes, they would be. I personally am always more comfortable doing another one because people might say different things to other people, or they're more comfortable saying things to others, or something might have been missed, but I always want to hear it myself. Don't trust anyone else's screening. Yes. Okay, Mike, he is not casting a shadow because I'm not that great at Photoshop. Okay, so this is your scene. So it is a warm and sunny spring day. He is on the sidewalk outside of this rec center. The daughter says that she dropped off her father so that he could go get his vaccine. It's been over an hour because he went, got it. He sat inside for a while. She came to pick him up. He was waiting outside for her. And so, yeah, he's been out in the sun. So this is our guy here. He is now on the street, but it is not, there aren't cars coming and going. Do vampires have strokes? One never knows. Yeah, so this is our guy. Hazards, it is a roadway. There aren't too many cars. It is outside. It is just the one patient. The daughter says that when she came to pick him up, she thought he was having a stroke, and she says it's because he got all pale, he was sweaty, he said he felt like he was going to faint, and he said that his chest hurt and he was talking funny. So she thinks he's having a stroke. Do we want to upgrade our PPE, or are we happy with surgical mask and face shield and gloves? And this is our general impression. As you walk up, we've got a male, looks to be in his 80s, late 80s. He's sitting on his walker. He's alert. He's tracking you as you walk up. He says he's had no recent cough, cold, flu, fever, no sore throat, no illness, no nausea, vomiting. So if you're comfortable with your COVID screen, you can keep going. So his LOC, he's alert, he's talking to you. People are asking for his ABCs. So his airway is patent as he's talking to you. His breathing is normal, and his radial pulse is weak and irregular. How's his speech get him out of the sun? So his skin is a bit pale, but it's warm and dry right now. You don't see any kind of diaphoresis or sweatiness like his daughter said. Get him in the shade? Yep, we can absolutely move him maybe back into the building. RBS, no physical findings. So you complete a fast test. I should say RBS other than this fast test. So you complete a fast test, you notice right away, you have him do the arm drift test, and his right arm drops immediately. He's got some right-sided facial droop. You try and get him to do a grip test. You say, hey, hold my hands, squeeze my hands with both your hands as hard as you can, and he can't do it. Like, he's just not squeezing your hands at all. When you walk him into the building, you notice he's dragging his right foot a little bit. And then you ask him to name your pen and name your watch. And he just kind of stares at them. And after about 10 seconds, he says he doesn't know. So people are saying call 911. Absolutely. Yes. Are those things new for him? That is a great question. So the daughter tells you that he'd been having some TIAs lately. And 2 weeks ago, he had a full-on stroke, which has left him with some deficits. So the right side facial droop and the right side kind of dragging his leg is not new for him. The daughter says he's been doing that for the last couple of weeks. So his first set of vitals, you get a heart rate of 100 and irregular heart rate, respirations of 20, blood pressure 150 on 90, SpO2 95% on room air. His skin is pale and dry, and you take a sugar because you have that ability, and it comes back as 4.9. So what is new then? So the daughter has no idea if that right side arm drift is new because she didn't know how to test that before. And she says that he's normally pretty sharp. So she thinks that he would be able to normally name a pen and watch and stuff. So that might be new. Medications and allergies. So he very handily has a whole list written out. So he is on hydrochlorothiazide, which is a diuretic. He's on amlodipine, which is for hypertension. He's on venlafaxine, which is an antidepressant, essentially. He's on levocarb for some Parkinson's, nortriptyline, which is used for neuropathic pain, anxiety, depression, rosuvastatin for high cholesterol, losartan for hypertension. He's got cyclobenzaprine, which is a muscle relaxant, and he's got pantoprazole for his acid reflux. And his medical history, he's had 3 MIs in the past. He's had a section of his ascending aorta replaced. He has a history of his esophagus twisting. He's got diabetes, he's had TIAs, and he had that stroke 2 weeks ago. And currently, he is presenting with some chest pain. And like the daughter says, he got pale, he got sweaty, he felt like he was going to faint. No nausea or vomiting. Last meal, so he had breakfast before coming to the vaccine clinic. So this is around noon right now. Sounds like a TIA and angina altogether. Yeah, so it's kind of funny that the daughter runs in saying, I think my dad is having a stroke, but then she lists off all of these like very cardiac symptoms. How does he manage his diabetes? Oh, I'm sorry, I left that one off the list. My list is double-sided of all of his medications. He takes insulin and other diabetes meds. Is ASA available? Yes, it is. Do we want to give him aspirin? No, yes, no, 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 yeah. Is this cardiac? Is this a stroke? So he has some very clear stroke-like symptoms, but he's also got chest pain. He was pale, sweaty, diaphoretic, kind of sounds like presyncopal as well. So what would we like to do for this patient? We called EHS a little bit earlier. Update 911 with cardiac/stroke symptoms. Sure, we can do that. Oxygen. We haven't put on oxygen yet, did we? We can put on some oxygen. What would we like to give him? A low flow cannula? Sure, we can do that. So we do another set of vitals. How's his anxiety? He doesn't seem anxious at all, really. Is the irregular heart rate normal for him? The daughter doesn't know, but she's kind of assuming that it is because he's had this whole host of many medical problems in the past. So she's basically says she wouldn't be surprised if it was, but she's unsure. So your second set of vitals, and we've got him back inside in a cooler spot. We've got him kind of resting. We've got some oxygen on him. His current vitals are heart rate of 90, still irregular. Respirations still about the same at 20. Blood pressure 138 on 88. SpO2, 97%. And he still looks pale, but the daughter says that he is not as pale as he was when she first saw him. Did he just get a vaccine, or is this just outside the clinic? Yeah, so he went and got his vaccine, and he was in the kind of recovery area for about half an hour before going outside and waiting for his daughter. Can we grab a nurse from inside? Sure. What would we like the nurse to do? What is his normal blood sugar level? 4.9 might be normal for many, but might not be his normal. That is an excellent question. And I don't have that answer for you.
I really liked the question you asked, Anna. What would we ask the nurse to do? Oh, Kyra says to screen for common post-vaccine effects. There are common post-vaccine effects include a sore arm and maybe feeling a little bit lightheaded for a couple of minutes if you have a thing about needles. Those are probably the only post-vaccine effects that we would expect.
Yeah, so Kyra, the nurses at the vaccine clinics, they don't have blood pressure cuffs or SpO2 monitors. They don't have anything. Basically, at the vaccine clinics, they have a binder for anaphylaxis protocol which has epi and syringes in it. And there's a bed. So a lot of the reason why St. John is there is to kind of take over that side of things so they can keep vaccinating. But right now, St. John is stocking kits with SpO2 monitors. We can't do glucose, but for the sake of this scenario, I'm giving you a blood sugar reading.
A bit late for an allergic reaction, and I'm going to very respectfully disagree with you on that one, Mike. I've personally seen, not in relation to vaccines, but in relation to other things. We do sometimes see anaphylaxis delayed by up to 30 to 60 minutes after exposure, even with injectables at times. It's not super common, but I wouldn't use that timing to rule anything out. Until you've been like 3, 4, 5, 6 hours post exposure, I wouldn't be ruling an allergic or anaphylactic reaction out. Just my 2 cents.
Is it possible to give him a bit of sugar? Yeah, you can absolutely get him. There's lots of juice boxes at the clinic. You can get him a snack. See, just to rule out whether that sugar is actually low for him. See if that fixes anything. Did we ask about last meal? Yeah, we did. So it's around noon right now, and his last meal was breakfast time. All right. Any other assessments we want to do with him? Any other questions we want to ask? Any other thoughts about what's happening, what should be done? Sounds like multiple issues at the same time exacerbating each other. Yeah. Did the sugar help? It did not help. No. You notice that if you redo a fast test, his arm drift is gone. He can hold up both arms together. And he is now able to name your pen, your watch. So he's got no aphasia, but he still has the facial droop, and his right leg is still kind of weak and dragging. Is it a TIA again? Yeah. Would he be able to say if it felt like previous TIAs? He would not know. Could be hypoglycemia. Would a hypoglycemic patient present with arm drift? Like it was a very pronounced drop. There are a lot of, there's a lot of kind of symptoms he's got that fit into multiple categories. Sounds like a TIA that resolved but sent to hospital anyway. Yes, this guy should definitely go to the hospital. Okay, EHS arrives. So we tell them we've got a male in his 80s. And then you need to really present a good story with this man because he's got so many symptoms. So you need to be clear, like the daughter came in saying he had a stroke. She initially saw him presenting with diaphoresis. He was pale. He was speaking funny, as she said. He felt like he was going to faint. You came and did a fast test. This is what you found. This is what his initial vitals were. We've given him oxygen. We've moved him inside. We've laid him down. We gave him a bit of sugar. And this is how he's presenting now. His the query knew stroke-like symptoms have resolved, but he still has this remaining pre-existing stuff. And just really paint a good picture of basically everything that transpired, because he is a weird, complex patient with a lot of really questionable pre-existing medical history. Any comments, questions, discussion about this guy? A neurologic syncope. Maybe. What was the final diagnosis? So I unfortunately do not know. I am still waiting for the follow-up on this patient because I have someone who works with him who is going to follow up. I don't know. So with this guy, he is a high-risk patient because he's had this repair on his aorta. Does he have something dissecting that's causing his brain to not get enough oxygen, and therefore he's got the neurologic symptoms? Is this a TIA that's presenting as a large vessel occlusion? Is it something else altogether? I don't know. He's just got such an extensive medical history that he needs to go in and get checked out by the professionals. If he does go in, I mean, they're going to do a CT of his head, of his abdomen. They're going to check cardiac function. They're going to do a lot of stuff on this gentleman because of this cardiac history and all the other stuff that he's got going on. So yeah, he's an interesting one. Anybody have anything to add or questions? Nick, you always have a tidbit of information.
I think I threw in everything that I wanted to. I was just actually typing back and forth on a direct message with Mike here about the query allergy for this. I think for a bunch of reasons, I don't think this guy's presentation matched an anaphylactic or an allergic reaction, but we were just talking about latent exposures and or latent allergic reactions. Yeah, I mean, I think my prevailing impression with this guy is that his chief complaint is that he needs to go to hospital to be assessed by a physician, and that like there's like 5 different things that I can think of that are all relatively sorry, I'll turn my camera on here, that are all relatively likely or relatively reasonable candidates for what could be wrong with him, and absolutely none of them are things that I can rule in or out in the field. You know, he needs to go to hospital to have probably an ECG, blood work with tropes, maybe an abdominal ultrasound, um, possibly a CT if he represents, and so on and so forth, right? Uh, Absolutely none of this is stuff that I can go anywhere even close to touching in a pre-hospital environment. Let's call an ambulance and send him to hospital. And if I was wearing my work hat, I'd probably drop a line in him on the way, maybe put an IV in his arm or something on the way up. Um, I I'm generally stumped. I wouldn't hang my hat on any suspicions one way or the other with the patient as I've sort of had him presented to me today or right now. So
Yeah. Someone's asking about a chief complaint. Like when we bring a patient into the hospital, the triage nurse is like, so what's wrong with him? I'd probably be like, a lot, and then go from there. Um, there's so many things it could be. He just needs to go in and get a whole bunch of tests done and imaging done, blood work, all sorts of things. So what can we do for him? I think the course of action we took was the right one. We put him at rest. We gave him oxygen. We did a really good history. We decided against ASA. Yes, he's got these cardiac symptoms, but yes, he's got these stroke-like symptoms. So ASA is kind of ruled out there.
Kyra asked a really good question here. Can that be a chief complaint? Awesome. I think that was in response to his chief complaint is that he needs to go to the hospital for assessment. I mean, I'm being a little bit tongue in cheek when I say it that way out loud here in this presentation, but a chief complaint of unwell list of symptoms is not unreasonable. Pre-syncopal, no chest pain, history of stroke, or neurodeficits, pre-syncopal, feels unwell, right? These are very, very vague, nebulous, almost, I mean, not quite meaningless, but they're very, very non-specific complaints. They're not a very helpful chief complaint in that they don't help like really narrow things down in the chief complaint. But something like that does tell whoever's reading it, whatever healthcare professional's reading it, oh, well, we're not quite sure what's going on with this guy, but he needs to go and get some lab work and some diagnostics done.
Yeah, what Nick said. Okay. Hand over stroke-like symptoms, history of stroke and TIA, changing, improving neuro findings. Yeah. I mean, you want to present, you also want to include what the daughter saw. When she describes him as being pale, diaphoretic, pre-syncopal, and then these stroke-like symptoms. And then list off the history because he's got a lot of like red flags in his past medical history. So any other questions or comments? This was my last scenario. Anything you want to discuss? Maybe any questions about treatment guidelines or PPE? I know more of us are starting to go out on duties. So if there's maybe questions about the order of putting PPE on or when to put it on, when to wear a gown, what to do if you have a patient that presents as whatever, I'm happy to answer any questions.
Anna, is Mike fitting anybody for N95 masks anymore?
He could be. If you want to be, I can arrange that.
I signed up for one of the weekend shifts next weekend. I have been fitted, but it was a year ago. I don't know if that fitting is still appropriate.
A year is kind of the cutoff. I can arrange something with Michael.
Mm-hmm.
Are patients with shortness of breath usually willing to wear a mask? It really depends on how you play it. So I've had patients at work that have a history of major COPD, and if like they're usually willing to wear it. Give them some oxygen. Like if you put in a nasal cannula, put the mask over top, that's usually a good thing. But generally speaking, I haven't had much pushback from people with shortness of breath. If you put it on and it really bothers them, then you can take it off. Can we use our N95 fitting from our work with SJA? So if you have been fit tested in the last year and you have access to N95s, then you can wear them.
The important caveat with that in response to Carly is that it has to be the same like brand model number. It has to be the specific N95 you were fit tested with. So like even for example, a 3M 1870 versus an 1870 plus requires a different fit testing. So as long as you got the exact same N95s, I think it would be reasonable, but I don't actually know the official St. John answer. Even if there's a very slight variation in style, though, you need to be retested on whatever you're going to be using.
Yes, yeah. So if your division carries an N95, you need to be fit tested for that specific model. If you were fit tested at work and you have access to those N95s at St. John, then you can. If you are professionally fit tested for a half mask respirator, you can bring those, but you have to remember that you need to keep the exhaust port covered up with a surgical mask. Linda asks, is there a need to be fit tested first before going out on duty? No, there is not. So the standard at St. John is to wear a surgical mask with a face shield.
I just wanted to jump back. Someone just really briefly to Nancy's question: are patients with shortness of breath usually willing to wear a mask? In my experience, I just want to address this really fast. My experience has been that the vast majority of people who struggle with wearing masks, the underlying reason for that is emotional anxiety or psychiatric anxiety rather than an actual like medical issue, biological medical issue that is preventing them from wearing their mask. It doesn't make their anxiety issue any less real to them, but yeah, or fogging glasses. Absolutely. I don't wear glasses now, but I did for a very long time. I can't wear my sunglasses at work with my surgical mask on. It drives me nuts because I just fog it up right away. And she'll say Island Health is misapplying face masks. Yeah, absolutely. But very often, I'd say the vast majority of the time, people who are struggling to wear face masks or wear face masks properly can often be coached through that process. I haven't personally yet seen a patient who has had a physiological reason that they were unable to tolerate a mask. I've seen many patients who have had anxiety around their mask use and have felt like they can't wear it or don't want to wear it or they feel claustrophobic or whatever. I have yet to see someone who's been directly physiologically impacted by the presence of a mask. So a lot of how well someone tolerates masks can be how you talk to them and coach them. Yeah, I see someone here who says, I get some anxiety sometimes with my dental appliance and a mask after a long while. Absolutely. And, suggesting that I'm not at all suggesting that anxiety around mask wearing is not something that needs to be addressed. But the way we address that can very often be some verbal coaching and emotional support to get someone through that. And please don't like hold it onto the patient or something that will make their anxiety worse, and it's also assault. But don't do that. But being able to coach someone through this and explain to them why it's important and why it has to happen. And it's everyone, it's not just them, and so on and so forth. I haven't yet had a patient who that hasn't worked for, yet. So just to throw that out there as well, calm, cool, let's have a discussion about this. You know, it's important for us to be able to treat you safely, and we need you to wear this, and blah 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 blah, and all that sort of thing. Can go a really long way into getting your patient to actually keep a surgical mask on them. The other thing, I didn't see anyone actually ask it, but it's maybe worth mentioning, is that the standard, and I don't know if this is actually written down anywhere for St. John or not, but the standard should be medical grade masks, not just cloth masks. The reason for that being that, you know, the fabric that you got from insert local fabric store / local mask manufacturer / Etsy's, whatever, you don't really know how good that is at filtering droplets and aerosolized stuff out. And we do know how good medical issue masks are. So it's, you know, if your patient walks into you wearing their own mask, just politely ask them to switch into a surgical mask. Yeah, I see Kyra saying Canadian Blood Services doing medical masks. Sure. I mean, the hospitals haven't been accepting non-medical masks for 6 or 8 months now. I mean, really since last summer, at least, I think. Don't hold me to that date. Quite some time. You know, I have yet to have anyone really give me any pushback on that at all, but just something to tuck in the back of your head. Hey, thanks. We're happy to help you out. Would you mind swapping your personal mask for this one, please? And you know, then you're dealing with a known quantity and not a question mark. So be my only my 2 cents.
Yeah, I haven't really had anybody cause any issues over the mask wearing. Sometimes, like Nick was saying, it just takes a bit of reassuring or coaching, and people are pretty willing to work with you on it if you spin it the right way. So someone was asking, oh, sorry, go ahead.
I was going to say, I see Andy. I assume it's Andy typing. Maybe it's Shirley. I'm not sure. It's one of the Philpots. I have a friend that only has one ear and just wears their mask with straps that go behind their head. I've run into this a bunch of times with people with head injuries. And by head injuries, I mean injuries to the head, not cerebral injuries. But where we've ended up with wound dressings or bandaging over an ear or something like that. You know, I've managed to come up with a bunch of creative solutions, including tying 2 masks together so that they kind of go on like front and back, and one of them is just there to hold the other one in place. If someone has wound dressings around their head, sometimes I'll just tape one side of it down, use like a big, like 8-inch long tag of tape, and then the other one loops over an ear. Yeah, you can sometimes have to be a little bit creative with this stuff, but you know, there's I have yet to find a patient that I haven't been able to get a mask onto either. So sorry, Anna, I just wanted to respond to that really fast.
Oh no, it's all good. Someone was just asking if all this PPE, face shields and stuff is supplied by St. John. The answer is yes, your division should have the supply of face shields and surgical masks and gowns and gloves and all that stuff for you to go out on duty. And then some of the vaccination clinics will have a bunch of stuff available for you as well. Does anyone have any other questions or comments, things they'd like to say? We've been using the clinic stock. Yeah, might as well. Like if Interior Health or Northern Health or Island Health is paying for it.
Maybe just to echo that as well, Anna, thank you very much for an excellent session again tonight. I know these have been really popular the last time we did this, and it looks like again tonight. So thank you so much for putting these together. I know you spent a lot of time working on these and building these as well, especially the incredible Photoshop skills, which I really do appreciate. So I'll say maybe a quick thanks to everyone for attending this evening. We do hope to have someone set up for next week. Oh, the question of not using your own masks came out last week. Yeah, I got to be honest, I haven't been paying a huge amount of attention to it. It's just it's good practice to just use the medical grade ones. Swap them every few hours on yourself, and use medical grade ones, especially if you got a beard, they start to get a little bit scratchy and stuff. They get fuzzy on the inside. So, but yeah, if there's no more questions, thank you, Anna, for a fantastic talk tonight. I do hope to get the certificates and everything for tonight pushed out, hopefully even tonight, guys. Actually, I'm pretty well set up to get the stuff done this evening. So, yeah, thanks everyone. Have a great night. We hope to see everyone next week.